yesterday we had discussed about ultrasound of the pelvis, right? Where we discussed about how do we take images of uterus. We also discussed some important pathologies about uterus. Today in this session we'll be seeing about ovaries. Yeah, the let us start from basics again. So I always start with this image. So you know that this is the female reproductive system. Now, unlike uterus, which is a single organ, there are two ovaries, one on the right and one on the left. So always when you are observing or whenever you are reporting in a scan, you always have to look for both of this, that is right ovary as well as left ovary. Second important thing is that these ovaries are located just adjacent to the uterus and you won't be able to see this fallopian tube. Normally, fallopian tube is not seen on ultrasound, normally. But if it is distended with what? Fluid. Or if it is distended, what do we call? If a fallopian tube gets distended with fluid, this is called hydrosalpinx. So if there is hydrosalpinx, or if there is pyosalpinx, good Fauzia, yes, it is hydrosalpinx, or if there is pyosalpinx, in those conditions, we would be able to see the fallopian tube. Okay. Another important thing is that this, you know that there is a fallopian tube, at the end there are fimbriae, and then you have got ovary. So when you do, there are two ways of doing ultrasound of the ovary. One is transabdominal scan and one is transvaginal ultrasound. Okay. So when you do transabdominal scan, you would be able to see ovaries just adjacent to uterus. In case of transvaginal scan again, where the probe is inserted into the vagina, you have to manipulate it such that you see the ovary just adjacent to the uterus. Okay. So we'll be seeing, so this was about anatomy and applied anatomy moreover, so that you understand that where you need to look for. Again, I know that I discussed much of basic consideration even in my yesterday's session, but some of the people might be new. So for them, the probes which we used for examining ovary in ultrasound, the fundamental probe which is used in adult females is convex probe, or this is the abdominal probe. I always tell you that this is the preferred probe, especially in adults, where you want to have more depth. So the depth of this probe is high. Okay, but the resolution is not good as compared to this probe. This is a linear probe, or also called SP or superficial probe. This is preferred for superficial structures. Okay, and this is preferred if you want to look for ovaries, especially in young females who are very young, that is less than 18 years. Okay, especially 10-year kid, and you want to look for ovaries, then always SP probe or linear probe is better than the convex probe. Similarly, if there is an obese patient, suppose there is 15 years female, but female is obese. Now, which probe would you prefer? You would prefer convex probe. Why? Because you want more depth. Okay. The second important prerequisite after this, before we start doing ultrasound, is that you need to have full bladder. Why full bladder? I always tell you my favorite statement: fluid is the friend of ultrasound. Air is the enemy of ultrasound. So, if you want to look for uterus, uterus lies behind the bladder. So, you need to distend the bladder. That is especially in case of transabdominal ultrasound. Yes. So, in TAS, you need to have full bladder. But whenever you are doing, whenever you are doing a TVS scan, that is transvaginal scan, in all those cases, you know that the probe has to be inserted inside the vaginal canal. So you cannot have a distended bladder. So when you are doing TVS, the bladder has to be empty. So very important, TVS, empty the bladder. TAS, bladder has to be distended, well distended, full. Now, you know that where do we go for TVS ultrasound? When we want to look for uterus, okay, ovary, okay. But most importantly, if female is married, okay, so TVS ultrasound is only done if female is married. And second important thing is it's always done with consent and in the presence of a female attendant. So remember, three things are most important when it comes to TVS ultrasound scan. Okay. Now, this is again, identify this probe. We have already seen this. So this is a very good. This is a convex probe. Now, this marker, what you are saying, this is called indicator or marker. Okay, I discussed about this even yesterday, but just to have a revision part, always you have this such a sectorial ultrasound screen, and on that screen, on one side, you can see this marker. Now, there is a knob on your ultrasound keyboard, where you can, you can change this marker from this side to this side. Okay, you can change this marker. So depending upon what orientation you want, you can change this marker. Usually we keep this marker on the right side. Okay. Now this is transvaginal probe or TVS probe. So it, of course, this is an endocavitary probe, and it has got this protruding or proboscis like appearance, which has to be covered by barrier, which is condom, and the marker over this lies superiorly. So if this is a probe, instead of, in the sides, if this is a probe which is to be inserted, the marker lies here, that is superiorly. Okay. So that when you insert the probe inside, this marker should lie above. So this marker should be facing above. Now, this is how the probe is inserted into the uterus. We had discussed about this even yesterday. Now, coming to this probe, it has to be covered with a barrier. Now, I'll tell you something which I did not tell you yesterday. Now, see, normally there is a problem with how people put barrier over the probe. Suppose if this is a probe, what they try to do is they just put a barrier over this and they try to stretch it. They try to stretch this below. So what happens is this barrier ruptures. This barrier ruptures, which is a wrong method. So once you have to keep profuse jelly over this probe, put a barrier over this, and then you have to unroll it. Then you have to gently unroll it. Don't pull it. Okay, you have to unroll it. So that is the way you have to put a barrier over the probe. Okay, there was one question regarding this, so I've cleared that. Now, next important thing, as soon as you go in this, you would be getting uterus along the longitudinal section. Now, you know that ovaries are adjacent to this. So, you would have to make a side movement of the probe in order to reach towards the ovaries. So, now this is how you have got a TVS probe, which is to be covered by barrier. Always universal precaution are to be followed whenever you have TVS ultrasound. Okay. Always take care, if the patient is bleeding, you need to apply a poly drape below it so that your bed or your table doesn't get soaked with blood. This is very important. These are all practical points, not mentioned in books. But when you take patient for ultrasound, and then after doing ultrasound, you find that your bed is filled with blood. So when you take, most important, take consent. Female attendant should be there. Next is you put a pillow under her waist. So if this is patient, you put a pillow under her waist. Okay, this is the cranial end. So you put a pillow under her waist and you take her in lithotomy position, just like we do it in case of delivery. And the table should be like this, the gynac table which we have. Okay, because only then the supero-inferior, that is antero-posterior or supero-inferior manipulation of the probe is possible, or else your probe won't go below this end. So you won't be able to visualize nicely. So always you need to have end on table. Okay. Okay. Now let's move ahead with this. So ensure that the patient has got empty bladder, clean probe, insert probe into the patient's vagina, get into the anterior fornix and obtain the sagittal section. Now, what are the sections? We have got sagittal section, the coronal section and the transverse section. Now, this is a thorough thing about any organ in the body. But when it comes to ovaries, Okay, when it comes to ovary, most important are two sections. So one we will call it as longitudinal section of the ovary, which looks somewhat oblong like this. Okay, and second is the transverse section of the ovary, which looks like this. Okay, this is the transverse section. So if you cut ovary along this, it will look like this, right? It is just like cutting a potato slice. So transverse section and longitudinal section, and then you have to take this diameters. So this distances AP, trans, and CC. So you have to take these three diameters. Okay, always three diameters have to be taken whenever you want ovarian volume. So what is the formula for ovarian volume? AP diameter into transverse diameter into craniocaudal diameter in centimeters upon 2. Okay, upon 2. So for example, you have got AP diameter of 5 centimeter, transverse diameter of 2 centimeter, and CC diameter of 2 centimeter. The volume would, these are all in centimeters, so volume would be this divided by 2, which comes out to 10 cc. Okay, so sometimes just if you know the length, you can calculate out the volume using this formula. I tell you, this formula is not just used for ovaries. It can also be used for any other collection. So suppose if there is any collection and you want to find out the volume of this collection. So simple method is you have to take it as AP into trans into CC and divide it by 2. Yes, Zainab, you are correct with this. You have calculated the volume very correctly. So very good audience. I enjoy with you people, you know. Now coming to planes, of course, we have discussed this. So we have sagittal plane, coronal plane, transverse plane. But in ovaries, we have two important plane, longe and trans. Okay. Now let's see the fundamentals of anatomy and then let's move ahead. So of course, you have got two scans. That one is, this is transabdominal ultrasound and this is transvaginal ultrasound. Always in transabdominal ultrasound, which is this organ? This organ is urinary bladder, correct? And this is distended with fluid. That denotes that this is TAS, okay? So always the first thing that you should notice as soon as you start doing TVS is whether the bladder is empty or whether the bladder is full, okay? Always take care of this. These are simple things, but you have to take care, okay? Now, this organ, what you are able to see just behind the bladder is the uterus. Okay, this is uterus. Most of us are aware, those who have already attended my yesterday's session, but just a brief review for those who are new. So this is cervix, this is the body of the uterus, and of course, this is the ET, which is the endometrial thickness. Now, this is the vaginal canal. Now, this is, you are in mid-sag section. Now, where do I want to go? I want to go just lateral to it where the ovary lies. Okay. Now, this area which is there behind the uterus, this is called POD or pouch of Douglas. So, normally you should not have any fluid in POD. If you are able to see such anechoic appearance over here in POD, then it is abnormal. Okay. Similarly, in TVS scan, again, you would be able to see this uterus nicely. Okay. Now, when you measure uterus, you have to take distance like this. So this distance, and you have to add. So this would give you the craniocaudal length of the uterus. And this is ET. Chalo. So briefly, the urinary bladder has to be nearly empty when you are doing, almost empty when you are doing TVS scan. The ET is measured from end to end. This entire hyperechoic thing is the ET we had seen yesterday. Now we move ahead to technique of ovarian ultrasound. So let's start. So first is transverse view. Okay. So look carefully. Again, same, just like you have in uterine ultrasound. We have placed the patient. The probe is held such that we are able to get a transverse image. Okay. And now look here. This is the uterus at the center, and you have these two ovaries in the periphery. So depending upon the marker, very important. So you should know that this is the marker side. This is the marker side. So normally, suppose if you have kept the patient, so this is the patient, this is the right side, this is the left side. You see that the marker is on the right side of the patient. That means this ovary is belonging to which side? This ovary is of the right side, and this ovary belongs to left side. Remember that many a times, due to hurriness or due to sometimes, abnormal holding of the probe, people often confuse right with the left, left with the right, and mistaken reports comes in the market. Okay. So now let us see how we do ultrasound of the pelvis. So look here carefully. We are directing the ultrasound rays such that it cuts the uterus exactly in midline. And now we are moving in the parasage direction. So we are sweeping like this, parallel to the longitudinal axis of the body. And are you able to see this? This is the ovary. Okay. Now again, see, we are sweeping on the opposite side through the body of the uterus. So you are able to see that how we are sweeping. Okay. Now this is how the transverse section are to be taken. They were longitudinal. So now this is the ultrasound probe. This is the marker, the green colored. Yeah. So now you are able to see this is how you move the probe. So marker faces towards the head end of the patient. Now this is how you take a mid-sag image. Okay. So we have, so now this is the orientation of anatomy. So see, look here, this is bladder, this is the uterus. And so you would be able to get this section along the uterus if you put the probe in this direction. So this is the section which is obtained. So from anterior to posterior, this demarcates the anterior wall of abdomen. And this entire organ, anechoic, is the urinary bladder. Anechoic means completely dark. Now this green marked organ is the uterus with the vaginal canal. Okay, you can see that there is some heterogeneity here that denotes this is some previous LSCS scar. Now this green colored marked thing, this is the ET, endometrial thickness. Okay, so now this is how uterus appears in mid-sag. Okay, now as soon as you reach uterus, now you have to pan it. Okay, look for any focal lesions if any, and then move in the adnexal region, and now you'd be able to see the ovaries in adnexa. So this is how you see ovary very clearly. And not just that, you are able to see that there are peripheral arranged follicles. So this is ovary. Okay, this is the ovary. Note, very important, for transabdominal scan, the bladder has to be full if you want to see ovary very clearly, or else it would be a problem. These are the ovarian follicles. Okay, these are the ovarian follicles. Now, if you see the angle with the cervix, slightly posterior, that is because of LSCS scar. Now, this is the ovary on the opposite side. Again, it is showing follicles. So, this is how a normal ultrasound of ovary should look like. Okay. So, this was ovary in longitudinal section. Similarly, when you want to observe it for transverse section, you will have to move probe perpendicular or 90-degree to this. So now you see here the probe is more perpendicular to what it was initially. And now you are able to get this image. So this is the, will be swiping inferior most area. This is anterior wall of the abdomen, urinary bladder. And now these three lines denote the vaginal canal. The central hyperechoic denotes the air. And now we are moving high up. So this is the uterus. Okay. See how we are sweeping it. You have to sweep from posterior. So you have to sweep from inferior to superior direction. Now this is the right ovary. This is the transverse section of right ovary. And look well, you won't be able to see much of the fallopian tube structures unless it is dilated. Now this is the ovary on the left side. So this is the ovary on the opposite side, this one. Note very well that iliac vessels lie posterior to this ovary. So if you trace the iliac vessels, you would be easily able to trace ovary. Okay. So in young patients, it is easy to get ovary. But in old patients or fat females, it becomes difficult to trace ovary. So in all those patients, it is very useful trick if you trace the external iliac group of vessels. So go on tracing that, and then you would be able to see the ovary just anterior to it. So now this is the method which I was discussing. So look here. So here we are taking transverse section and go as much inferior as you can, such that you see square shape or rectangular bladder, okay, quadrangular bladder. Now direct your probe to the side where you want to see the ovary. You would be able to see this iliac vessels, and now trace this iliac vessels superiorly. So now sweep the probe, move it superiorly. Okay. Yeah. So now you are tracing this vessel superiorly. So now, yes, trace, 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 trace. Yes. And now here you get this ovary. Okay. This is the ovary on the left side of the patient, and you are able to see one cyst, so that can be measured. Now this is uterus. Now similarly, when you want to look ovary of the opposite side, again angulate it such that you see the iliac vessels of that side. So yes, these are the iliac vessels of the opposite side. Once you get this iliac vessels, you can see the color box, the external iliac artery, which is showing the flow. You trace it high up, and here comes the ovary. Here you are able to clearly get the ovary. Once you come to the ovary, focus ovary in the center of the screen. You take it along the launch section. You can take a dual screen and make it, launch and trans. And this is how you can take ovarian volume. Chalo. So hope the ovarian ultrasound, the technique becomes very clear through trans-abdominal way. Now we see how transvaginal ultrasound is done. I had shown you even yesterday, but for those who are already there, it would be a revision. For those who are not there, for them, this would be a new thing. So look carefully how TVS ultrasound is done. So you have to gently insert the probe after taking a gynac protocol on your screen in ultrasound machine, and as soon as you insert, this is the view which you get. Okay, now this is the cervix, and this is the section which you get, which is the mid sagittal view of the cervix in the longitudinal section. Ureter and iliac vessel differentiation. So how do you differentiate? So this is a very good question which one of the student has asked. I will pause here. So the question is, how will you, in a normal ultrasound without Doppler, can we trace the iliac vessels? Yes, you can. Even without Doppler, you can trace the iliac vessels. So how? I'll show you. I'll show you one image. So this is a very good question, and it helps to solve many problems in ultrasound. So I'll show you here. Be attentive. So see, iliac vessels would be looking anechoic structures like this. And normally you know that anechoic, so artery and vein lie side by side, correct? So there will be an external iliac artery and an external iliac vein. Now, very important, how is artery? Artery pulsates. Okay, so if you see it with a probe, you would be able to see that the diameter decreases and again increases, again decreases, again increases. So this is called pulsatile vessel. So artery is pulsatile, whereas vein is not pulsatile. Okay, number one. Number two, ureter is not seen unless it is dilated. Remember, ureter is not seen unless it is dilated. Ureter is seen only if it is dilated. Of course, ureter is not pulsatile. And any machine, any ultrasound machine always has a provision of color box. So you can always put a color box and you can see if it's artery, vein or a ureter. Ureter will not show any color flow, whereas artery vein will show color flow. Okay. Chalo, hope that solves the question. Now we come back to a video. So now we are able to see that in the lower end, after TVS examination. So yeah, I'll go back so that so we have done TVS. This is the view which we get. As soon as you get this, see, we are adjusting the depth. This is what we have. We look at the cervix. So whatever the part to be examined, it has to be focused well on the screen. And now we are panning. So look how we pan across through the structure. So now on TVS ultrasound, this region is the anterior. This is the anterior aspect, and this is the posterior aspect. Okay. So whatever structures lie here, they are anterior, and whatever lie behind, they are posterior. So this so whatever structures lie here, they are anterior, and whatever structure lie behind, they are posterior. So like you see, this is uterus or this is cervix, whatever. And so this wall is the anterior wall, and this wall is the posterior wall. And can you see this? So this would become the pouch of Douglas area, and this is the rectum. Okay. So this lie the posterior part. So you have to be very careful when you are deciding which is the side. So now the probe should be oriented such that the eye is facing upwards. Okay, this is very important. Chalo. So now let's move ahead. So whenever you want to take the transverse section of anything, you have to just move the probe to 90° and you would be able to see the transverse section of the image. Okay. So now I hope that this becomes very clear, and another video which would help you to see this. So this is how I want you all to see how we manipulate the probe in this video. So see, when you want the mid-sag and parasag, see, this is the movement which has to be performed. That is side to side movement. This is called sagittal sweep. Okay, sagittal sweep whenever you want to look for ovaries. Okay. Now again, how do we look for ovaries? So prepare the patient in lithotomy position. Probe is inserted. After proper consent, after proper preparation, after you tie the barrier, at the end of the probe, you are able to visualize the uterus. Once you see the uterus, you move in the adnexa. So now this is the uterus. You are able to see very well. So now this is anterior region. This is posterior. So this is anterior myometrium. This is posterior myometrium. This is the pouch of Douglas, which lie posteriorly. Got it? So this is empty bladder, which lies anterior. Now this is pouch of Douglas. This is POD or rectovesical pouch. So always look for rectovesical pouch if there is any fluid which is present in it or not. Now again examine for the uterus, look for ET, look for empty bladder. Sometimes if there is mass within the uterus, it might displace or it might invade the bladder. So this is anteriorly the bladder. Now this is the posterior aspect where you are able to see this airfield would be the rectum. This is the uterine fundus, the endometrial stripe. Now never forget, you should sweep through. एक image मिला उस पे diagnosis नहीं करना है. You have to sweep through it so that a छोटा fibroid, the small fibroid or small lesion, small cyst is not missed out. Okay, never forget sweeping. Many a times I see that there is a fibroid in the lateral wall, which is often missed. So that gets missed because just you put the probe, you see it in mid-sag section, you look at the ovaries and just give it off. So that should not happen. You should sweep it properly, and always, rule of thumb, try to look anything in two views, AP and transverse. So how you have noticed that the probe is moved 90° to what it was initially. And here you are able to see the right adnexa and the left adnexa. And now we are panning it in up and down direction. Okay. So starting from bladder, next comes is the uterus. And now here comes the rectovesical pouch, and this is the rectum. So this is how you have to sweep it in up and down direction in order to gain the image. Now this is the right adnexa where you are able to see the right ovaries. Fallopian tube, as this is dummy patient, you are able to see it nicely, or else in actual patient, you don't see it. Okay. unless it gets filled with fluid. Sometimes the patient might have gross ascites. If patient has gross ascites, again that would make ovaries and fallopian tube nicely visible if there is gross ascites. Okay. Now see here, this is fallopian tube and this is left ovary. Now here, this is a fake mass lesion which is seen in the left adnexa. Okay. And this is a fake corpus luteal cyst. So now hope that this clears about the ultrasound part, how and the technique part of ovarian ultrasound. Okay, the transabdominal method, the transvaginal method to visualize the ovary. Now, how does ovary appear on ultrasound image? So this is how ovary looks. So this is a transvaginal ultrasound image, TVS. Always remember, TVS is best when you want to look for ovaries. TVS is much better as compared to transabdominal ultrasound. Why? Because resolution of TVS probe is the best and you are near to what you want to look for. You want to look for ovaries and you are very close to the ovaries. Second important thing, sometimes if you take transabdominal scan, you might not see the ovaries. So in those patients, again, you can take a TVS scan and ovaries get visualized very nicely. Now, commonly used indication where we do TVS, one is follicle monitoring. So normally when patient comes for follicle monitoring, usually many a times you will find that these patients are fat, obese patients. And when they come, you keep on searching for the ovaries, you don't get them. So sometimes you have to do manipulation, that is ask the patient to put hands under their waist and ask them to raise their waist. Okay, so that the entire pelvis gets pulled up and you would be able to manipulate more and the ovaries get visualized. Second important thing which is very important when you want to look for ovaries is that ensure that the bowels are emptied. Bowels are emptied. So what happens if bowels get empty? This is very useful in those patients जहाँ पे ovary दिखते ही नहीं or it becomes very difficult to look for ovaries. So ask them to empty bowels and do the scan in early morning. Okay. So whenever we do follicle monitoring, usually preferred time is early morning because bowels are empty. There is least amount of gas after emptying bowels. So this is the preferred time when after emptying bowels with minimal gas to look for ovaries. Now, once you get ovary, you would be able to see such an image. So this is where I am outlining the entire ovary. This is how ovary appears. Now, let's come to fundamental anatomy. Ovary has got two parts. Do you remember the fundamental anatomy? Ovary has two parts. One which is called outer cortex, which has got developing follicles. And second, it has got an inner stroma or medullary region. Okay, this is the inner portion. So here you are clearly able to see this developing follicles. Okay, these are all follicles. So when you see them, what do we label this? These are multiple follicles. And if you see them, the size, all of them, most of them, the size is less than 10 mm. So none of these are dominant. Dominant follicle means that follicle which would ovulate in the next cycle. Here almost all of these follicles are similar in size. And how are they? They are anechoic, anechoic and peripherally arranged. And this is the stroma. So this is how ovary appears on ultrasound image. And you call them as MSF, multiple small follicle, which are peripherally arranged. Now there are other criteria when ovary becomes bulky, when do we call it PCOS, etc., etc. We'll see in subsequent slides. But this is how ovary appears. So this image should be fixed in your brain. Many a times people confuse vessels as ovaries or people confuse, other structure as ovaries. So you can just put a color box in this. So these follicles will not show color flow, whereas the vessels would show color flow within it. Sometimes, huh. So now, of course, this ovary is not normal. It has got multiple cysts, what we call it as polycystic ovary. But this is how ovary appears on ultrasound. This is the main aim to show this image. Okay. Next is, look here. In this ovary, you are able to see a well-defined anechoic cyst. So this is a cyst within ovary. Now, how do we identify cyst? What are the criteria? Number one, if it's a cyst, it has to be anechoic. That is, it has to be completely dark. Number two, it should have posterior acoustic enhancement. What do you mean by posterior acoustic enhancement? If you compare this area with the area just posterior to the cyst, you are seeing that this is bright. So area which is posterior to the cyst becomes brighter than the adjacent area. Look here, this is a cyst. Now this area which is just posterior to the cyst, it is brighter or hyperechoic as compared to these regions. So this is called posterior acoustic enhancement. So posterior acoustic enhancement is a very important sign that this is a cyst and not a solid tissue. Next important sign is vascularity. You won't see that there is vessel in the cystic region unless there are solid areas within it. Okay. Okay. So now let us start with this. So what do you think? What is the finding which I am showing you? Very good, Razida. So this is classic. Very good, Rashmi, Fauzia. Everyone has answered it correctly. So this is one of the very common pathology which is encountered in our practice. Good, Zainab. So now this is called PCOS, polycystic ovarian disease. Here you are able to see that the ovaries have become bulky. Okay. So ovary is bulky, more than 10 cc in volume. Okay. Next is, if you see that there are multiple small follicles, none of them is dominant. None of this is dominant. Okay. Now, if you see, none of these are dominant. All of these are small and they are arranged in periphery in a garland fashion. So this is this is called string of pearl appearance, which is classic of PCOS. Now, in our course on Iqramed, we have got entire series of lectures on all of these ovarian pathologies. So ovarian cysts, PCOS, I have put lectures on endometriosis, all of this. So all important pathologies, I have put detailed discussion on each of this. So you can go through, and Sultan Ansari would be sharing all of the links and the website details. Now, coming to PCOS. So, of course, you know that this condition is characterized by hyperandrogenism. Along with this, there is an ovulation. This is very important. Why do you think there is an ovulation? Because there is no LH surge. LH continuously is raised. There is no LH surge. So remember that in order to have ovulation, there has to be LH surge. What lacks in PCOS is there is no LH surge. There is constant elevated level of luteinizing hormone. So normally you should have like this, LH low and then LH surge, and then it is normal. It gets decreased. But in case of PCOS, you have constantly high level of LH. Other things which are infertility, hirsutism, obesity, acne, and insulin resistance are the other important features which are seen in PCOS. But why is PCOS very important? Number one, because it is increasing these days. Number two, this is a reversible cause, treatable cause of infertility. Out of many causes which we have, this is one such cause which is easily treatable. And as a result, diagnosing PCOS is must. Huh? Chalo. So now there are various criteria, one is Ishar and ASRM criteria. What I want you all to remember is that ultrasound is very important evidence for polycystic ovaries. And see, whenever I see polycystic ovaries on ultrasound during my practice, I don't label it as PCOD. Many a times you might see that the patient fits for PCOD ultrasound wise, like you might have that sonography findings like polycystic ovary in both ovaries, that is volume is more than 10 cc, and 12 or more follicles which are less than 10 mm. So if you have more than 12 follicles, that is antral count, and the ovarian volume is more than 10 cc. But if patient is clinically all right, menstruation is okay, biochemically patient is okay, then you cannot label this patient as PCOS. So in that case, we use a special term on ultrasound which is called PCOS morphology. So morphology of the ovary on ultrasound is like PCOS, but clinically the patient might not be PCOS in some cases. Okay, so always you have to mention on report that this is a PCOS morphology. However, you have to correlate biochemically. Okay, and this is the criteria. So the set of criteria for diagnosing PCOS is there has to be oligo-ovulation, this or anovulation. This is a very, very important criteria, and there has to be 2 out of these 3 criteria to call it PCOS. Second is clinical or biochemical signs of hyperandrogenism. And third, ultrasound evidence of PCOS. Just on the basis of one, you cannot call it as PCOS. At least 2 has to be there, 2 or more than 2. Okay. Now, PCOS normally lacks ovulation. So if you see a cystic ovarian structure measuring larger than 1 centimeter, the evaluation is not considered valid and a repeat ultrasound has to be performed. Okay. Now, so this is how you have to count each of the antral follicles in case of polycystic ovary. So this is how you have to take volume. So number one, this is ovary in longitudinal section. This is ovary in transverse section, same ovary by TVS. So of course, जिस position में you get this image, you have to turn the probe to 90 degrees so that you get this image. Okay. And you can see that there are multiple peripherally arranged tiny follicles giving pearl necklace appearance. Okay, and you see that the follicle count is almost 16, 17, so which is more than 12. That indicates that this is PCOS. If you see the volume calculation, so this is one distance, this is the second distance, and this is the third distance, AP trans and CC. And if you calculate the volume, it is coming out to be 15.6 cc, which is more than 10 cc. That means this fits for polycystic ovarian morphology. Okay, this is PCOS morphology. If any one of this other criteria is there, either the biochemical signs or the oligo-ovulation, then we would call it as PCOS proper. Okay, now I'll show you a few slides dedicated to follicular study. So when you do follicular study, especially in case of PCOS, just now we had discussed about PCOS. So it's better to discuss follicular study together. Right? This is called linking topics. Okay. Whenever you study something or learn something in life, you have to link it. Anatomy पढ़ो तो उसको link करो clinical life से. If you do radiology, link it to anatomy like that. So this is how you will remember the subject well, and your fundamentals of the subject, your diagnosis will become very good. Now, coming to follicular study. So whenever you are doing follicular study, there are two important things. One is called entral follicle count, and second is called follicle monitoring. So what is entral count? We have already seen this in the image, right? So here you saw that we count each and every follicles. So that is called entral count. Normally we do a baseline entral count to see how much is the ovarian reserve. There are hormonal studies also, but on ultrasound, what you do is you count all this entral follicles. Usually we do it initially, that is in second day of MC, where we don't expect any dominant follicle. So agar second day of MC pe you are able to see some anechoic structure which is more than 30 cc, that means that is a cyst, because we don't expect any follicle to be there on second day of MC. So usually entral count is preferred so that any cyst and all can be diagnosed early, and you don't mistake a cyst for entral count. Entral follicle count, it is preferred on either day 2 or day 3 of menses in order to prevent the effect of intracycle fluctuation. However, evaluation of ovarian reserve by follicle count may be performed at any point Okay. Now, during early follicular phase of the menstrual cycle. Why early phase? Because during early phase, you know that there is secretion of FSH, that is follicle stimulating hormone, and this FSH helps for development of the follicle, and as a result you have to do antral follicle count in the early phase of menstrual cycle, that is during the FSH wala or the follicular phase. So now the antral follicle count must commonly be done. It is usually done using a 2D probe. Now there are 3D softwares also, but doesn't make much difference. So basically it's sweeping through the ovary and you have to count how many follicles are there. So, and then what you have to do is total follicles in the right ovary and antral follicles in the left ovary, you have to add them. And that gives the total AFC, that is antral follicle count. So all the follicles in the range of less than 10 mm, that is 2 to 10 mm size, are counted in both the ovaries. That gives a measure of ovarian reserve. Is ovarian having follicles or not? That is understood with the help of AFC. Okay. So AFC can be done using 2D technique or 3D technique like this. So we have softwares which directly, gives you the image in one sweep, and also it gives you the antral count. So that is what you can have. But if you do not have 3D, even 2D is sufficient, and you can count it on 2D image. Next is antral follicle count is a very good method for determining ovarian reserve because it gives us the valuable information associated with ovarian pathologies. Like suppose you took a patient on day 2 and you are able to get this image. Is this follicle? Answer is no. How should the follicle be? Follicle should be in the range of 2 to 10 mm and it should be clear and echoic. Here what you are able to see? You are able to see net-like pattern. So what is this? Can anyone tell me what is this? What is the image showing? Yes, ovarian, Razida has said ovarian cyst. Some has said chocolate cyst. Some has said hemorrhagic cyst. Okay. So this is always a confusion, right? Whether it's a chocolate cyst or a hemorrhagic cyst or just a cyst. So I'll also talk on them. Now, now what I want you all to remember this image. This image ko yaad rakho. How does it look? This looks like, yes, Zainab, correct with this. So let me explain you. This looks like this. Okay. ध्यान से देखो इस image को. What is this appearance called? This is called fish net appearance. Machhi ki jali, okay, which is used to catch fishes. So this is just a fish net appearance. Can you see that? Lacy reticular appearance or fish net appearance. So whenever you see, correct, this is also called spider web appearance or cobweb appearance. Okay, and just looks like a spider web or cobweb. So this is very classic of hemorrhagic cyst. Okay, we'll also discuss the classic appearance subsequently in our further slides. So by now it becomes very clear to all of you how important antral follicle is and how hemorrhagic cyst looks. So it has got a fishnet appearance. Okay, I have made a detailed video on this also, how to differentiate various types of cysts. Now coming to follicular monitoring, so it has to be done based on the day of the cycle. So usually the initial days we do the antral count. Now we monitor it starting from the day 9, and then we continuously monitor till the formation of the Graafian follicle and when it ruptures. So that is how the monitoring is done and formation of corpus luteum takes place. So you have to identify the one follicle. So now suppose if you see you are doing follicle monitoring, initially क्या दिख रहा था? सारे follicles जो छोटे छोटे हैं, they are there arranged in the periphery, and अचानक से you get one follicle which is increased in size. When this follicle goes more than 10 mm, that means it's a dominant follicle. And you have to identify the dominant follicle. Yaad rahe, if there are two ovaries at a time, only one ovulates. So either you will get dominant follicle in the right or in the left, but not both. Remember, okay? It's very rare that both of them would ovulate. Okay, that leads to formation of dizygotic twins. So now you see that there is ovary and you find that their follicle which is more than 14 in diameter, that means it's a dominant follicle. Now this follicle has to be monitored daily. It grows at the rate of 2 to 3 per day. Okay, and it has got no internal vascularity, no solid areas, and it has got a thin non-perceptible rim. Very important. How do you differentiate dominant follicle from corpus luteum? So ये important point है, ये दो. It does not have internal vascularity or peripheral vascularity like that you see in corpus luteum. We'll see what is that. And it has got a thin rim. Okay. So mature follicle, once it matures, it enlarges in size to around 16 to 18 A shadow develops in surrounding, like you see in this case. Okay, layer, and this is called cumulus. Okay, which approx 36 hours before rupture. An irregular flimsy line may be seen surrounding it. Okay, that denotes that this is about to rupture. And you might see that in periphery there are some increased vessels. Okay, it won't show a ring of vessels. It will show that there are periphery increased vasculature. So once it ruptures, you know that it will lead to formation of corpus luteum. So blood vessels cover at least 3/4 of the ring. And almost 90% of times the RI is less than 0.5 and PSV is more than. What is RI? Resistivity index. So RI is just given by the machine. What you have to do is you have to put the color box in the flow which you are getting, and you put your uh, gate inside it. Okay, so once you put it, what you get is you get this waveform. You can trace any of a good wave, and once you trace it, you get these values. That is PSV, that is peak systolic volume, and second is RI values. Okay, they are calculated by the machines, and if PSV is more than 11 or RI is less than 0.5, it denotes that there is ovulation which has taken place. Okay. Chalo. Up there are two important signs which I would like to show you. I'll show the image so that it becomes very clear first. So suppose this is ovary and there is a mass lesion. This is ovary and there is a mass lesion. Okay. Now, how will you understand? Is this mass arising from the ovary, or there is a mass which is arising somewhere from exterior and it is compressing ovary? So you have got a sign which is called a beak sign or claw sign. So if the mass is arising from the ovary, it would make acute angle with the ovary. See here. So if a mass makes acute angle, this is called claw sign. Mass is held like this, like a claw. But if a mass is extra ovarian, what it would do is it will compress the ovary. And if you see the angle between the mass and the ovary, it would be obtuse angle. You look here, the angle between mass and ovary is obtuse angle. So this tells you that it is extra ovarian and it is not a ovarian mass. Okay. Now let us move ahead. So the few of them in last slide gave the answer hemorrhagic versus chocolate cyst. So in this few slides, I would clear up those doubts which you people had. So first, we'll see three important cysts: follicular cysts, the corpus luteum cysts, and the hemorrhagic cysts. So follicular cysts, when do it occur? When does it occur? When the dominant follicle which has developed does not ovulate and the cyst becomes more than 3 centimeter. This is called follicular cyst. Very important. Both of these lines are important. So suppose बहुत बार you see that some people have labeled 20 का cyst है. 20 का cyst is not there. It can be just a dominant follicle. समझा? So you have to label a follicular cyst when it becomes larger than 3 centimeters. Remember. When can 20 cyst be there? In postmenopausal female. In postmenopausal female, we don't expect the follicles to be there. Okay. So in those females, you can have even if 20 cyst is there, you have to report it. Most of the follicle cysts, they lose the ability to produce estrogen. On ultrasound, we see them as unilocular cyst, anechoic cyst. I'll show you the image so that things become very clear. So this is classic appearance of simple follicular cyst. Now, let me recollect. Jitne bhi signs we had discussed, all of these are seen in this image. Do you remember? It's very well defined. Imperceptible wall. You are able to see posteriorly there is, what is this? This is posterior acoustic enhancement. If you compare it, this region with this region, this is hyperechoic. That denotes that this is posterior acoustic enhancement. That means this is a cyst. It is clear. No septa, no calcification, no internal vascularity. And if you put a color Doppler, you can see minimal vascularity in periphery. Okay, nowhere, not much vascular like we see in case of corpus luteum. Okay, and are you able to see this? Now, one more important thing. Now look here, this one. This is ovary and this is the cyst. So now I ask you the question, is this cyst arising from ovary or is it compressing ovary? That means, is it ovarian or para-ovarian? So the answer is, it is ovarian. Very good. Why? Because big sign is positive. Very good. So it is making acute angle. Good, Zainab. Good, Rashmi. And you are able to see that as there is acute angle with the cyst, it means this is ovarian in origin. Okay. Again, here you are clearly able to see this big sign positive. Okay. Next is, so you have understood about follicular cyst. Now we come to a second important cyst, which is corpus luteal cyst. So corpus luteal cyst is when corpus luteum is formed and it fails to regress. Normally corpus luteum gets formed, it remains if pregnancy takes place, and it regresses to corpus albicans if pregnancy does not occur. So if even in post-ovulatory phase, it fails to regress following release of the ovum and it fills with fluid or blood, then it is called as corpus luteal cyst. Now, remember, do you remember that in follicular stage, the dominant follicle which has failed to rupture develops into follicular cyst. Once it suppose if it ruptures, becomes corpus luteum and then fail to regress, it becomes corpus luteal cyst. So the difference is the formation phase. One is formed during follicular phase, whereas second would be formed from the corpus luteal phase. Now, a very important thing is the appearance. So now look at it. I want you all to remember the appearance. How is the wall? The wall is hyperechoic. The wall is thick. So thick hyperechoic with what? A classical appearance which is there here. So if you put a color box in this, you would be able to see ring of fire appearance. Ring of fire appearance. And now look here. This is ovary. And this is corpus luteal cyst within it. Again, can you see the big sign? So that means this is present within the ovary. Now, where else do we see ring of fire sign? Or kahan dikhta hai? Where else do we see ring of fire sign? Yes, very good. So ring of fire is also seen in ectopic pregnancy. So good Zainab, good Rashmi, good Shobna. I enjoy teaching you people. Good. You're interactive and that, motivates me because, I'm just talking in front of camera. The answers motivate me, to teach you more. So ectopic pregnancy. So ectopic pregnancy is one where you have to differentiate it from corpus luteum cyst. So how do we differentiate? Any idea? So now normally, see, look here. What is ectopic pregnancy? GSAC is located outside the endometrial cavity. So this is how the uterus, this is fallopian tube, this is ovary. Okay. And this is the endometrial cavity. So suppose there is a G-sac, and G-sac ideally should be located where? Here in the endometrial cavity. But if it is located here outside in the fallopian tube, then it is abnormal. Correct. This is abnormal. And how, if G-sac is in ovary, how do you differentiate? Yes, Farin, that's the question. How do you differentiate? So now, number one, see, if G-sac is in fallopian tube, you can easily differentiate. Remember, ectopic pregnancy will occur on that side where you see corpus luteum. तो जिस साइड corpus luteum दिखेगा उसी साइड पे ectopic pregnancy होती है. Okay, because that ovary has ruptured, so the ectopic has to be there on that side, right? So if they are separate, you would be able to see the ectopic separately and corpus luteum separately. Now, which is the most common ectopic to take place? Is it ovarian ectopic or fallopian tube ectopic? Which is the most common ectopic? The answer is, it is fallopian tube ectopic. Very good, Neha. So, exactly. So, everyone is very clear with this, that it is the fallopian tube ectopic which is very common. We don't get ovarian ectopics very common. Once in a blue moon, you might see, ovarian ectopic. So, what is more common? Fallopian tube ectopics. So, always remember, if you are seeing this claw sign and the structure is present within the ovary and it is showing ring of fire, don't label it as ectopic. Okay, this could be just corpus luteum. Ovarian ectopic का diagnosis तब होता है when you see fetal pole within this. If you are able to see fetal pole or yolk sac within this corpus luteum looking structure, then you would be able to say that this is ovarian ectopic. Okay, and of course, one of the important sign which Rashmi has highlighted, there will be two ring of fires. One is fallopian tube ring of fire, and second is the corpus luteal ring of fire sign. Okay, so in this case, where there is ovarian ectopic, it should not be labeled unless you see a fetal pole or yolk sac within it. When you are able to see either of this structure, only then label it as ovarian ectopic, or else no. Okay, or else it's better to follow it up. So now, sometimes it might happen that, like it happened in this case, people labels corpus luteal as some, ovarian lesion, and MR is suggested, and patient undergoes an MR, and here you can see this ring of fire sign on MRI. Okay, so this is corresponding to ring of fire sign on MR. How do you differentiate ruptured ovarian ectopic and corpus luteum? Zainab, that's pretty easy. Ruptured ovarian ectopic would in that case you need not even search for corpus luteum. Why? Because as soon as the ovary ruptures, you would have lots of hemopy. Ovary is highly vascular structure. So when ovarian ectopic ruptures, it's dangerous. You will have lots of hemopy, and at that time you are very sure that if UPT is positive, hemoperitoneum is there, you might sometimes see the ovary or sometimes not see the ovary, just a little big hematoma or an adnexal mass. That is sufficient to diagnose it as ruptured ectopic. Okay. Many a times in ectopic, you would just see that the main ectopic pregnancy is not seen, but in a big hematoma would be seen in adnexa, and there is fluid in POD. But if you have just these two things, this is sufficient to diagnose it as ruptured ectopic. Next is hemorrhagic cyst. Okay, so let's discuss this. Here there is hemorrhage into the follicle which has developed. So follicular cyst जो हमने देखा, when there occurs hemorrhage in that, this is called hemorrhagic cyst. Or corpus luteal cyst, what we have seen, when hemorrhage takes place in this, that again becomes hemorrhagic cyst. Okay, now hemorrhagic cyst, usually on an average the diameter would be similar to that what we saw in follicular cysts or corpus luteal cyst, that is 3 to 3.5 centimeter in diameter. It can also be larger than this, and very important, hemorrhagic cysts are painful. Okay, follicular cysts might not be painful, corpus luteal cysts might not be painful, but hemorrhagic cysts are painful. So, बहुत बार clinicians, they send it to us, eating our head. Is it torsion? Is it torsion? Is it torsion? So remember that a bit of pain is also there in hemorrhagic cyst. Not necessarily it would be torsion. Okay. Now coming to, let's see, depending upon the stage of hemorrhage, the appearance of hemorrhagic cyst could change. Imagine this as cyst. Okay. Suppose this is cyst. I'll show you the various stages of cyst. Okay. So you'll have to follow it with me, what I'm showing you here. Okay, I'll use a different color. Acute hemorrhage. What would you be saying? Fine moving echoes. Right? So if you see that there is a cyst, patient is having pain. First time, doesn't have it with every menses. पहली बार दर्द हो रहा है. Okay, या फिर intermittent pain. And there are fine moving echoes in this. What does this denote? This denote there is acute blood. Okay. So fine moving echoes, this favors, this is acute blood. So this can be one appearance of hemoperitoneum. Of hemorrhagic cyst, where you can just see fine moving echoes. Now, as time goes, what happens if you take a blood in test tube and just put it? So the plasma goes above, and the RBCs settle down. So you would be able to see that RBCs settle down and plasma comes up. This is called hematocrit phenomenon. So just like the blood which settles in test tube, now the bleed which has taken place inside the cyst will also settle down. So RBCs will go down like this, and the plasma would come up. This is called fluid level. Fluid level. The RBCs which settle down in the bottom, they are hyperechoic. And this moving echoes and the clear plasma which comes above, it becomes hypoechoic or anechoic. Okay. Plasma is anechoic and RBCs are hyperechoic. Okay. Yeah. So RBCs are hyperechoic, plasma is anechoic or hypoechoic. Now let's move ahead. So now suppose with time. So yes, Farin, that's a good question. It happens after how much of time? So you see this for around 1 to 3 days. 1 to 3 days. You see this appearance. Next is, with time, what will happen? This starts forming clot. This starts forming clot. And there is clot formation. Now what happens is, once there is clot formation, so initially you might see such appearance, where periphery mein thoda fluid hai, and there is in center there is clot. This clot will look hyperechoic. So now it becomes hyperechoic. Then what happens is, this clot would be taken up by the macrophages with time. So this clot would retract. So after few weeks, you would be able to see this appearance. This is called retractile clot sign. This is called retractile clot sign. समझ में आ गया? So the clot retracts. This is called retractile clot sign. Many a times I have seen that people give this retractile clot sign as the mass, but that is not a mass lesion. That is basically a phase of hemorrhagic cyst. They give this as complex cystic mass. They take, this is one cyst, this is second cyst, this is third cyst, okay, and this is fourth cyst, and they say that this is a complex cystic mass with some solid areas, and they advise MR. Okay, but this is just a retraction clot, retractile clot sign. Now, with time, as this clot is further eaten up by the macrophages, you find that it becomes lacy, reticular pattern, or you see a classic pattern which is called fishnet appearance. Fishnet appearance. So this is how you see that. And when it becomes chronic, you would see that there are few septa left, and after that it might resolve. So this is how the temporal evaluation of hemorrhagic cysts takes place. Okay. So depending upon the time period where you are seeing the cyst, it can show fine moving echoes, or it can show fluid level, or it can show retractile clot sign, or it can show the fishnet appearance, or it can show complete resolution. So ये है patterns of hemorrhagic cyst on ultrasound. It might show reticular pattern, cobweb, fishnet appearance, or retractile clot sign. As it cyst, it can show posterior acoustic enhancement, and it resolves with a follow-up. Okay, so don't be in a hurry to call anything as a mass lesion. What you should do is, whenever you are in doubt, you should just give it as follow-up. So follow-up is very important when it comes to all such cysts. Other features include internal echoes, retractile clots, septations, fluid levels. So all these are important signs. So now in this image, I'll be showing you. So fishnet image at least takes 3 weeks to appear. It doesn't appear immediately. So after retractile clot, we have got fishnet appearance. It takes time, at least 3 weeks to appear. Now look here in this. So first image, very important. What is the sign which we are able to see? This is classic fishnet appearance. Okay. Here, what is this sign? Are you able to see this? So this is a retractile clot sign in this cyst. Very good. So this is retractile clot sign. Good. Now, very good. So every audience is able to answer, and they are able to understand. That's great. Are you able to see this sign now? So inside the cyst, this is plasma which has come up. This is RBCs which has gone down. So RBCs which go down, they appear hyperechoic. The plasma which moves up appears anechoic. Correct? So this is fluid sign. Again, a sign of acute bleed, because this occurs in hardly 1 to 3 days. Okay. Yeah. So sometimes it might look like this, solid looking. This is when that is very acute clot which has not yet resolved. Okay. And this might be confused with a solid mass lesion. So here you have to put a vascularity box, that is color box. In case of hemorrhagic cyst, it's just a clot. So do you expect blood vessels within the clot? There is no. So if you have a hemorrhagic cyst, you will not show color flow within it. Okay. So color flow is absent in the clot of hemorrhagic cyst. Now see, this is how clot resolves. So initially it looks like this, which is showing fishnet appearance. Okay. With time you would be able to see that there are just few nets left. So this is how it resolves. And sometimes you and after a few months, if you see that it is completely resolved, nothing remains. Okay. So now what is to be done once you have a cyst on your scan? Two important things. You have to first see if it's a follicular cyst, corpus luteal cyst. So simple cyst versus hemorrhagic cyst. Once you make out that it's a follicular or corpus luteal cyst, you see if it's a premenopausal female or a postmenopausal female. If it's a premenopausal female with simple cyst less than 3 centimeter, कुछ नहीं करना है. Less than 3 centimeter, nothing is to be done. Follow up भी नहीं करना है. Simple cyst more than 3 centimeter, 3 to 5 centimeter, now need to be described in the report but does not need follow up. So you have to write in the report, but don't follow it up. It is mostly benign. If the cyst in premenopausal female is more than 5 centimeter, important. So more than 5 centimeter agar hai, this needs yearly follow up. Okay. And if it is more than 7 centimeter and difficult to assess with ultrasound, further imaging may be advised with the help of MR, or surgery may be considered. Now coming to postmenopausal female, I have told you even 2 centimeter cyst is 2 centimeter tak ka cyst hai, that is less than 2 centimeter, then need not be described or does not require follow-up. But if it is 2 to 7, so once it becomes 2 centimeters, now it needs to be described and yearly follow-up. And you have to see if it increases in size or resolves. And if it is more than 7, certainly you have to consider her for surgery. Okay. Of course, we do CA 125 to rule out malignancies. Now, hemorrhagic cyst. So, premenopausal female or postmenopausal female. If it is less than 3 centimeter, not to be described, not to be followed up. 3 to 5 centimeter, you have to describe it, but no need to follow it up. More than 5 centimeter, then you have to follow it up. 6 to 12 weeks follow up. Okay, once resolved, nothing to be done. Similarly, in postmenopausal female, you need, if it is less than 5 centimeters, it's needed to be described and 6 to 12 week follow-up has to be there. In early menopause, hemorrhagic cyst more than 5 centimeters should be considered, possibly neoplastic, and MR or surgical evaluation should be considered. Okay. Now, there are few tumors which just looks like hemorrhagic cyst, and hence, in those cases, MR has to be done. Okay, now I show you an image. What is it? What do you think is the image? Yes, I'm getting few answers. Very good, Rashmi. Very good, Fauzia. You're correct with this. So this is classic. So normally you see that ovaries are separate. But here what you are finding is that this is one ovary. This is the second ovary. They are stuck to each other. So this is called kissing ovaries, which is classically seen in case of endometriosis. Now we have seen like many appearances in case of uh, hemorrhagic cyst, but in endometriosis, the classic appearance which is seen is called ground glass appearance. I'll show you the image how ground glass looks. Okay, this is called ground glass pattern. Are you able to see this fine moving echoes in this? So this is chocolate cyst. Okay, if you see lacy reticular pattern, it's hemorrhagic cyst. But if you see this type of pattern, that favors this is blood in it, and this favors this is endometriosis. So remember this pattern. So are you able to see this? This is classic ground glass pattern, fine moving echoes. Okay, same, few echogenic foci in periphery. And sometimes, suppose patient, you know that endometritic tissue, if there is endometriosis, it bleeds with every cycle. So if there is acute bleed within that, so you would be able to see it with fluid levels. So if there is acute bleed, sometimes you see layers of blood. Correct. Okay. Now let's see. So what is endometriosis? Endometrial tissue at abnormal sites. So normally you have endometrial tissue within the ET or the endometrium. But if you have endometrial tissue at abnormal sites, it is called endometriosis. So like suppose this is ovary, sorry, this is uterus. And if you have endometrium in POD, it is abnormal. If you have endometrium in the ovary, it is abnormal. So what will happen? If there is endometrium anywhere else, it will respond to the estrogen and progesterone in the body. But the problem is, so it will proliferate, it would have secretory changes. But when the endometrium is to be shed, when this hormone level decreases, this ectopic endometrial tissue cannot shed. And as a result, it goes on accumulating inside. So very important history which you have to ask in patient with endometritis is pain with each menstrual cycle. Okay. So in endometriosis, there has to be pain along with each menses. So as soon as she has menses, she will have lots of pain in that region. Next important thing is because there is endometriosis, there will be lots of inflammatory cells which would come in surrounding of that. So there will be adhesion formation. So how will you understand that adhesions have formed between ovaries and the uterus? So there is a special slide test which is done. So what we do is we insert probe into the TVS, that is transvaginal probe. You look for ovaries. So suppose you are able to see ovaries, and suppose this is the interface between the uterus and ovary. What you do is you slightly insert the probe inside, like this. You thrust the probe inside. So if you are able to see that uterus and ovary, it slides over each other. Suppose uterus moves like this and ovary moves like this. That is, uterus and ovary slide over each other. This is normal. That means there are no adhesions between them. But if you slide uterus like this, if uterus slides like this and ovary also slides like this with the uterus, that means that ovary is adherent to the uterus. So this is called slide test positive. That denotes that there are adhesions between ovary and the uterus. Okay. So this is how you can see endometrial tissue most commonly in POD or in ovary, which can be painful. Okay. Now this is an interesting case where which probe have we used? This is a linear probe. Okay. Or SP probe. Here you are able to see the rectus sheath. So in para-umbilical region, this is a heterogeneous appearing. I'll change the color. So this is the rectus sheath, and in para-umbilical region, you are able to see this heterogeneously hypoechoic area, which is there. And on FNAC, so you can do a fine needle aspiration cytology of this. This turned out to be endometriosis, and patient was complaining of cyclical pain in this region. Rashmi, scar endometriosis is when we see it in scar of the uterus. So suppose there is a uterus, and in uterus there is LSCS region, and in LSCS there is endometrial tissue which pains. That is called scar endometriosis. Here you are seeing it in anterior abdominal wall. Okay, this is rectus sheath. Okay, this is in anterior abdominal wall, subcutaneous fat. Okay, you can call it in case of the scar of LSCS which lie in the anterior abdominal wall. That can be the term used, but sometimes when you speak about scar on the report, the only thing which comes in the mind of treating clinician is that scar means the uterine scar, correct? So whenever you are mentioning endometriosis, you have to be specific about the plane in which endometriosis is seen. So whether it's in the uterine body or whether it's in the proper subcutaneous tissue or in POD, ovary, etc. So this is again a chocolate cyst. This is classic appearance. So now this is the normal glass. How is normal glass? Transparent. You're able to see this? And this is the ground glass. This is ground glass. This is white in color, but ground glass can be of different colors. We see it. So here this appearance is classic ground glass appearance. Okay. That is dirty looking appearance. This is classic of chocolate cyst. So I won't go into much theoretical details, just the findings. So you have got ground glass appearance, multiple loculations, varied level of echogenicity, sometimes punctate echogenic foci in the wall, fluid level with septations, solid appearing nodules, waxing and waning sizes. So this is again very important. So in case of hemorrhagic cyst, you have seen that with time, the appearance would vary in hemorrhagic cyst, right? And the size would go on decreasing. But in case of endometriotic cyst or chocolate cyst, what would happen? Suppose this is a cyst. With cycle, next cycle, it would bleed again into the cyst. So this would become large in size. With next cycle, what would happen? There is one more bleed into it. So the size would again increase. So with each cycle, you will find that the endometriotic cyst or chocolate cyst goes on increasing in size. This is one of the very important feature of endometriosis. Then because of scars, we see a special type of ovary which is called kissing ovaries. Okay, fine. So great. I would stop over here for today. Any doubts are most welcome. Comments are most welcome. So there are two questions. There are two questions in the box. Whatever questions are there, feedbacks, comments are most welcome. You can send me in the chat box now. Now, a question is asked by Rashmi: adenomyosis versus endometriosis image. So, adenomyosis is nothing but what? It is endometriosis of the myometrium. So, that is normally endometrial tissue is present in ET. If it goes inside the myometrium, you get adenomyosis. So I had shown you a slide yesterday where I showed you that there is loss of junctional zone between the endometrium and myometrium. This is very classic of adenomyosis. Whereas endometriosis denotes that endometrial tissue anyway. So endometriosis is a broad term. Adenomyosis is a part of it when it involves myometrium. In our lecture on adenomyosis also, yeah, we have given this. Next is hydrosalpinx. There is a question on hydrosalpinx by Fareen. So she mentions that how much time does it take to get resolved. So remember that hydrosalpinx, you have to find out the cause of hydrosalpinx. Usually in India, the cause of hydrosalpinx is peritubal adhesions, either because of active COX or because of past COX. So you would get it with every scan which you are doing. It won't resolve unless you remove out the cause. So if there are adhesions, those adhesions have to be removed. If the patient has complaint of infertility, okay. Similarly, if the patient has tuberculosis, that tuberculosis has to be treated. Only then hydrosalpinx would settle, or else no. You would find it with every scan. It was great, everyone. It was great to be a part of session today, and hope you have enjoyed this.